Hello, my name is Yezen. I'm an acute medicine, internal medicine trainee at St. George's. I'm also the founder at questmed.com. Today we will be discussing sarcoidosis and talking about the presentations, investigations and management of this rheumatological condition. So sarcoidosis is a multi-system disease. It causes an inflammatory response in the organ that it affects, and it is characterized by granuloma formation. So this is the first question, so please pause the screen to have a read. And the answer here is a bilateral parotid gland swelling. So sarcoidosis is an infiltrative disease that can affect the parotid glands, but it can also affect the lymph nodes and has an ability to go into almost any organ. Clubbing is more likely related to other diseases such as metastatic cancer, or localized cancer, and can also be caused by infections as well. Weakness that improves after physical exercise refers to Lambert-Eaton syndrome associated with small cell lung cancer. Bronchial breathing at the left lung base is associated with a pneumonia, and a hyperresident percussion note in the left lung is consistent with a pneumothorax. So sarcoidosis can have a number of presentations. The most common is Lofgren syndrome, which is also thought to be an acute presentation of sarcoidosis, which can come as fever, polyarthralgia, erythema nodosum, and bilateral hilar lymphadenopathy, and this is usually self-limiting. And as you can see, you have lots of other different presentations. So with pulmonary disease, you can get lung fibrosis, interstitial lung disease. You can get constitutional sarcoidosis, where you just have a bit of a fever, a bit of joint pain, and just generally feeling unwell. Neurologically speaking, you can get a meningitis or an encephalitis, but also one key thing that comes up in exams a lot is you can get bilateral Bell's palsy, or even actually unilateral Bell's palsy as well. Uveitis is very important and is a common presentation of sarcoidosis, and also restrictive cardiomyopathy as well. And finally, you have the abdominal presentations, hepatomegaly, splenomegaly, and also erythema nodosum we talked about before. Lupus pernio is a dermatological presentation on the nose. So here are some images. On the left you can see erythema nodosum, which looks like nodules, and it tends to be very painful. In the middle you can see bihilar lymphadenopathy, these chunky lymph nodes on each side of the heart in the middle there. On the right hand side, that is lupus pernio affecting the nose, and on the bottom is what you would expect to see when you're asked to look at histology in sarcoidosis, and that is what a granuloma looks like. So this is the second question. Please pause the screen and have a read. The answer here is raised serum ACE. So ACE can be increased in sarcoidosis. It's not diagnostic of the disorder, but it can be indicative of an inflammatory change, and it helps you to work towards that diagnosis. Serum calcium 1.6 is not correct because you may expect a hypercalcemia, and that is too low to be considered to be a hypercalcemia. You can get granulomas for C, but they usually are non-caseating granulomas. D, you would expect granulomas also in TB with Mycobacterium tuberculosis, but not in sarcoidosis. And finally, airspace opacification in the right upper zone would be more consistent with a pneumonia rather than sarcoidosis in itself. So the investigations for sarcoidosis, as we talked about, you would do a tissue biopsy and you look for non-caseating granulomas. You may get a raised erythrocyte sedimentation rate, raised ACE as we talked about, calcium would be raised, and you may also have reduced lymphocytes. Chest x-ray is very important, and the things you're looking for to start off with would be bilateral hilar lymphadenopathy, and as you can see, this can progress and become more severe with the stage 4 being pulmonary fibrosis, and that is probably more appreciated on a CT scan rather than a chest x-ray on the most part. This is the third question, so have a read, pause the screen. So this question is asking you about the treatment options in sarcoidosis. So the answer is oral prednisolone. So the key thing here is to appreciate that if you have someone who has stage 1 disease or just chest x-ray changes that are consistent with bilateral hyolymphadenopathy, on the most part this is consistent with an acute disorder that is self-limiting, so you don't really need treatment. The thing that changes things here is that they have evidence of a uveitis, so that painful right eye. So that would push you towards treatment, and therefore you would treat with oral prednisolone. Methotrexate can also be used later on in the disease and is definitely not first line. Equally with azathioprine, you wouldn't use that starting off. You may use it as a steroid-sparing agent later on. And C is treatment for tuberculosis, and this doesn't sound like tuberculosis at all. So the management, as we said, bilateral hyolymphadenopathy, self-limiting, and if in that case, usually acute sarcoidosis, you'd advise them to have bed rest and non-steroidal anti-inflammatory drugs. If you wanted to treat, you would start off with steroid treatment, oral or IV, depending on how severe it is. And later on, you may consider other immunosuppressants, so you can give methotrexate, for example. And later on, you can use things like monoclonal antibodies, which are being used more and more in sarcoidosis. So that's it for today. Here are some free notes about sarcoidosis. And if you have any questions, feel free to email me. Thank you very much.